Good afternoon. Welcome to the GI Hepatology Academy, presented by the Department of Continuing Education at Harvard Medical School. My name is Dr. Sanjeev Chopra, and you're tuned into the live session entitled, we actually have the wrong title here, so let me correct that, entitled Colorectal Cancer, Update on Diagnosis and Prevention, to be presented by Dr. Daniel Leffler, Beth Israel Deaconess Medical Center, Harvard Medical School. So please join me in welcoming Dr. Daniel Leffler. I just want to mention that Dr. Leffler is the Director of Clinical Research at the Celiac Center at Beth Israel Deaconess Medical Center and is an Assistant Professor of Medicine at Harvard Medical School. So welcome, Dr. Leffler.
Thank you very much, Dr. Chopra. It's great to be here. So today we'll be talking again about colorectal cancer, some of the more clinical aspects, some of the newer tests, and some of the things we may be expecting in the near future. So just some disclosures. But starting off, I just wanted to give a little bit of background with the epidemiology of colorectal cancer and how it breaks down. So it's about 60% sporadic, 30% familial, and then a minority have other specific syndromes, 5% with HNPCC or hereditary non-polyposis colon cancer, also known as Lynch syndrome. There's a few percent have miscellaneous rare genetic syndromes, and 1% have familial adenomatous polyposis. And so while there's a variety of things, the most important thing to remember is that the vast majority of people with colon cancer won't have any risk factor that you know about ahead of time. 60+% of them are totally sporadic. They won't have a significant family history. And this is why it's a screening test and not a risk-based endeavor. So to put a little bit more numbers on the epidemiology of colorectal cancer in the United States today, there are about 150,000 diagnoses, new diagnoses of colorectal cancer in the United States each year. And of these, about a third, or 50,000, will die of their disease. It is the second leading cause of overall cancer death and incidence in the United States overall in both men and women. And what you see in women is that the leading cancer incident cancer is breast, followed by lung and colon. Mortality in women is lung, takes the lead, followed by breast and then colon. In men, the most common cancer is prostate, again followed by lung and then colon. But the mortality, actually, although there's about 3 times as much prostate cancer as colon cancer, the mortality rate of the two cancers is actually very much equivalent. But again, so it's third leading cause of death and incidence in women and men separately. But if you take them together, because obviously prostate only affects men and women only affects, breast cancer only affects women, then it moves up to the second spot in the United States in the general population. So what does this mean for your patient in general, in specific? That means for men, there's about a 1 in 18 chance of developing colorectal cancer in their lifetime, and women 1 in 20. So this is a really very significant risk. This is something that is not academic in any way. This is something that each person in front of you in the clinic has a real significant lifetime risk of developing colorectal cancer. The major risk factors for colorectal cancer are as follows. They're increasing age. Males have a higher risk than females. A family or personal history of colorectal cancer and adenomas increase your risk of colon cancer. And we'll be talking about that specifically in a little bit when we talk about individual screening approaches to different individuals. And finally, inflammatory bowel disease with extensive colonic involvement is a major risk factor for development of colorectal cancer. And we'll be talking about that case very specifically. Other risk factors that are worth knowing about, although they are not as significant by themselves as the risk factors listed above, are people of African American ethnicity, obesity, heavy alcohol use, red meat, high amounts of red meat exposure. All of those in little bits and pieces can increase a person's overall risk of colon cancer. One risk factor that's been back and forth in some studies, which you may read about, is cigarette smoking. There was a strong feeling for a number of years that cigarette smoking was a major risk factor for colorectal cancer. It now seems predominantly that's a risk factor for rectal cancer and less so for colorectal cancer, but there are a variety of conflicting studies in this area. So That being said, although colon cancer is common and still has significant morbidity and mortality, there is some good news already. And what we see here, these are the cancer death rates among men, 1930 to 2005 from the CDC website. And what you see for colorectal cancer in the green line is that it was pretty much flat, pretty prevalent, and then around 1980 it started to decrease. This actually is similar, although the decrease in women started a little bit earlier. But again, we've seen a significant steady decline in colorectal cancer and mortality in both men and women over the last few decades. And there are probably a number of reasons for this, but it is felt that our efforts to improve colorectal screening in the general population, improving detection and prevention of colon cancer, are attributable to about 60%, 2/3 of this recent decrease over the last 2 or 3 decades of colorectal cancer mortality is due to increased screening and prevention as well as early diagnosis.
I wanted to interrupt you for a minute or so because there are already a number of questions coming related to epidemiology. And the first one is very interesting, and it's from Dr. Okinido in Beverly, Massachusetts. And I have a feeling he's standing as he's asking the question, because his question is there any known study linking colorectal cancer with prolonged sitting?
Yeah, so that is an interesting question, and it's clear that lifestyle factors play a big role in colorectal cancer. And some of those factors, like prolonged sitting, are actually very difficult epidemiologically to tease out from things like being overweight, which is a clear risk factor. And increased exercise seems to decrease your risk of colorectal cancer, as well as a few others. So I don't think there's any good evidence that sitting by itself increases your risk of colon cancer, but it's many of the other factors that are probably associated with prolonged sitting that lead to an increase in colorectal cancer.
Right, and Dr. Barbara Fleming is reminding us and the audience that breast cancer actually does affect men, but numerically, of course, it's much smaller than in women.
Yes, that's quite true. That was just a generalization.
Okay, great.
Anything else?
Please continue.
Thank you. So the other part is that as well as we were doing a better job screening and diagnosing early, there actually has been an improved stage-specific survival for colorectal cancer over the last 30 or so years. And what I did in this chart is actually put a couple of different cancers just to give a good rate and to show some proportionality. So colorectal cancer survival, so all patients coming diagnosed with colorectal cancer, is in the light blue bar. And you see in the 70s, it was just about 50%. And this has increased significantly to about 65 or so percent today. So a 65% chance of long-term survival at diagnosis of colorectal cancer. And this has been a significant improvement. And I would call this, in the general scheme of advances in cancer treatment, about middling. You can see some cancers, such as a darker blue with non-Hodgkin's lymphoma, have actually made a much more significant jump, jumping it from just above 40% to well above 70% survival today. On the other hand, we have cancers like pancreatic cancer in the purplish, which really have always been dismal and unfortunately have remained a dismal diagnosis, with still well under a 10% survival rate from that cancer. So again, I think there is plenty of good news regarding colorectal cancer. The mortality rate is going down, the treatments are becoming more effective, and our efforts at screening are making a big difference in the epidemiology and the overall mortality from colorectal cancer in the general American population. So given all this, and having made hopefully the argument that this is an important topic and a disease we should all be working to our best to prevent and diagnose early, what are our screening options? And these are really what they are today, and I'll go through them, each of them independently. The first is colonoscopy, flexible sigmoidoscopy, fecal occult blood testing or immunochemical blood testing, which can really be sort of thought of in the same way, fecal DNA testing, and most recently, CT colonography, and actually the most recent reports are actually of MR colonography, so imaging studies for colorectal cancer. And as we'll see, I think each of these has their role. And what we're moving away from, I think, for colorectal cancer screening, as well as much of medicine, is away from a one-size-fits-all solution, and really trying to figure out what the best test is for the specific patient in front of you at that time. So starting off with colonoscopy, this is really the mainstay of our colon cancer screening efforts in the United States today. And this has a number of really important benefits. It's a Q10-year interval, so there's nothing else that gives you so long between screening tests, and this is a significant benefit. Overall, the study suggests that it decreases colorectal cancer incidence by about 2/3, and it is considered a definitive test. There are issues with even colonoscopy, and we'll talk about some of those in a few slides, but again, it is the most definitive. It's sort of the gold standard currently. Unfortunately, there are limitations. It's invasive, it requires sedation, so patients have to take the day off from work, they have to get a ride home. All of these really increase the burden of the test. There's also a small but significant risk of adverse events. So 2 in 1,000 is the overall risk of adverse events from colonoscopy, and I'll give you some specific details about what those adverse events are. Requires an extensive preparation, which any of you who have undergone a colonoscopy know right now. And this is often one of the limiting things, especially if the patient is old, if the patient has comorbidities, then an adequate colonoscopy preparation just might not be possible. And it's also an expensive test. It's the most expensive colon cancer screening test currently.
Well, actually, Dr. Leffler, while we're on the topic of colonoscopy, a question just came up from Dr. Krishna Das. I have a patient who was detected after being diagnosed with strep bovis septicemia at colonoscopy to have a dysplastic adenoma that was resected. And the question is, does she need further surveillance colonoscopies in the future? So what should be the surveillance and how often in somebody with a dysplastic colonic adenoma?
Yeah, so I will actually be going through all the different surveillance recommendations in a couple slides, but just to answer that question, because that is important, and actually we can touch upon the strep bovis question as well. So anyone with a dysplastic polyp, depends a little bit on the size, but that's really considered an advanced adenoma. I would recommend that that person come back for a repeat colonoscopy within a year after the first one. Then after that, if that's negative, if there's not any evidence that there's residual adenomatous or dysplastic tissue, that can be expanded out to every 3 to 5 years, depending. But I think the viewer also raises a really important point, which is strep bovis bacteremia. So this is a condition which is associated very strongly with advanced lesions of the colon, either colon cancer or large polyps, dysplastic polyps. The actual reason why polyps or cancers lead to bacteremia and often even endocarditis or other tissue infections with strep bovis bacteremia is really unclear. But that being said, any patient who is diagnosed with strep bovis bacteremia under any circumstance, the very next thing they need to do once that infection is under control is undergo colonoscopy. The studies vary, but it's probably between 20 and 50% of those patients will have an advanced colonic lesion. So that's a very important message.
Terrific.
So moving on to flexible sigmoidoscopy, with or without fecal occult blood testing. So, and actually we've moved away from the addition of fecal occult blood testing from sigmoidoscopy in recent years because it is felt more and more that that adds little extra benefit to screening sigmoidoscopy. So the main, again, the benefit of screening sigmoidoscopy, a Q5-year interval. So again, not quite as long as colonoscopy, but still a fair amount of time between exams. The studies overall suggest a decreased colorectal cancer mortality by about 2/3. No sedation is needed, unlike colonoscopy. It still needs a preparation, but a much less extensive one, a much easier preparation to tolerate than colonoscopy. And it also has a decreased risk of adverse events compared to colonoscopy. Unfortunately, there are reasons why this has fallen out of favor in many areas in the United States, despite very good evidence of efficacy. Part of that is the concern of more significant proximal lesions. And overall in studies, it's about 10% of patients with a normal sigmoidoscopy have a significant proximal lesion. So an adenoma of 1 centimeter or greater is what's used in many of those definitions. It's of intermediate expense. And it may require follow-up colonoscopy. And this is one of the biggest issues that I think really we lack great guidance on from any of the studies or national guidelines, is what do you do with a patient who has a flexible sigmoidoscopy and is found to have an adenoma in the sigmoid colon, for instance? Do they need a colonoscopy right away because they've shown they have risk factors for adenomas and you want to look for more proximal lesions? Do they get a colonoscopy in 5 years where they would do when you would do a repeat sigmoidoscopy? Do you do something in between? And this is really an area that we lack good data for. There's been some modeling studies, but none of them really have suggested a very clear strategy. So this is something you want to talk about with your patients when they go for a sigmoidoscopy, saying, again, if we find something, we may need to do a colonoscopy. And the time at which you would do that colonoscopy is really sort of individual, anywhere from 1 to 5 years, certainly not more than that. So moving away from invasive testing to non-invasive testing, we have FIT, fecal immunochemical tests, or fecal occult blood testing. These are inexpensive, they are non-invasive, they don't require any preparation. They decrease colorectal cancer mortality by about 1/3. So clearly that's a significant improvement, but it is not quite as efficacious as colonoscopy or sigmoidoscopy. The other thing that is really important when you go into fecal occult blood testing or FIT testing with a patient, when you have that discussion, is to let them know that about 5% of these will have a positive test result. So they have about a 1 in 20 test result on a given day. So again, if you do this enough times, most people will have a single positive fecal occult blood test or FIT test. This rate actually increases if you are a patient on something like aspirin, NSAIDs, things that will cause a little bit of bleeding into the intestinal tract. Of the patients who have a positive FIT or fecal occult blood test, about 2% of those will have cancer and about 25% of those will have adenomas. So one of the issues that we do run into with fecal occult blood testing is that about 75% or so of people with a positive test will actually have no finding. But all positive tests require colonoscopy. And there is some anxiety, some issues that go along with the fact that you just had a positive test and then you get a negative colonoscopy. You're probably okay, but there is going to be that question in both your mind and the patient's mind. The other thing that is a cost of fecal occult blood testing versus the sigmoidoscopy, colonoscopy, is that they're much more frequent. FIT requires once yearly testing, and fecal occult blood testing requires 3 tests a year. And one of the things that I find, one of the mistakes I see a lot of people make, and we are most concerned about in especially the primary care setting, is the use of fecal occult blood testing as an in-office single test on a rectal exam. And that really is not adequate screening. It does not give you any, is not been shown to give adequate protection from colorectal cancer. So if your patient goes for the fecal occult blood testing or FIT route, it really needs to be an at-home sample. And with fecal occult blood testing, it needs to be 3 samples per year on different stool samples. It can't just be a single time all sent in. So those are all things to keep in mind.
Could I ask you a question? What is the acceptance rate on the behalf on the patients when you say, here's how you do it, you fish out your stool or use a spatula and smear it on this card and then close it, put some scotch tape, mail it to me? What is the actual acceptance rate? Yeah,
it's one of those things that often sounds a little bit better in the abstract and when you really explain to patients what it entails. And we do find that when, a lot of them say, I don't want a colonoscopy, I don't want to have to deal with all that. And then when you explain to them what it actually means to do a fecal occult blood testing at home, then they start to have second thoughts. But again, I think one of the things that I'll be getting back to again and again is that different tests are right for different people. And some people who have had perhaps a bad experience with invasive procedures before, or due to their social status are just not going to be able to get a ride to or from, there really might not be a better option than this. And I think, so just laying out all the different possibilities, and there are actually some great decision support tools online right now that can help take the patients through so you don't have to do it in your office, about what the different options are, what you can do, and what the pros and cons of each one are. But you're right, I think explaining to a patient exactly what this entails often gets them to shift to a sigmoidoscopy or colonoscopy.
So a question for Dr. Shamek Shah. 10 years interval for colonoscopy appears to be more theoretical rather than practical. We consider colonoscopy no later than 5 to 7 years to catch polyps. Would you please comment on that? And if it's really 10 years, how good is the adherence rate?
Yeah, so the viewer is quite correct. The 10-year interval for colonoscopy is really based on the known pathogenesis of colon cancer, the adenoma to carcinoma sequence. That being that it takes time for a polyp, a small polyp, to develop mutations and grow into a larger polyp and then off to a cancer that can metastasize. And that progress takes about 10 years on average. So he is quite correct. On the other hand, there are the studies that have been done of colonoscopy, both observational studies to a much lesser extent prospective studies, and unfortunately to a large degree modeling studies, really suggest that 10 years interval is probably about the right amount for an average population in terms of the costs, the risks and benefits of colonoscopy and screening. There's also issues now with accountable care organizations and insurance companies that may give us some question about shrinking the intervals beyond what are the general recommended guidelines. And I think that whereas there are some variations in accepted guidelines, and actually I'll be talking about some of those between the recent U.S. Preventive Health Task Force recommendations and the American College of Physicians guidelines, there are some differences. But all of them do suggest a 10-year interval for a patient at average risk without a past history of adenomas is probably a reasonable thing.
And while we're at average risk, what is the current recommendation for obtaining a screening colonoscopy in men versus women? Is there a difference in age?
Yeah, so right now we start men and women screening at the same age. In truth, if we had a fully rational system, we probably wouldn't. We would probably start screening women a little later and men a little bit earlier. But I think for many reasons, political as much as anything else, that is just a hard thing to do. Again, the one, and I'll jump ahead of myself while we're talking about that, the one population where we are starting to screen a little bit earlier is African Americans, because they do have a higher risk of polyps and colorectal cancer, and they do tend to develop at a slightly earlier age. So while guidelines give a little bit of, are a little bit vague still, and they give a little bit of wiggle room, I think we're quickly moving to a point where we can recommend colorectal cancer screening start at age 45 for African Americans and age 50 for the rest of the population. Moving on to our next test on our menu is fecal DNA testing. So this was 5 or 10 years ago, this was going to be the new big thing, and unfortunately this really hasn't panned out the way many of us had hoped. Again, it's a non-invasive test. It doesn't require any preparation, many of the same benefits as FIT testing or FOBT. It also clearly has a higher sensitivity than FOBT, but a similar specificity overall. Unfortunately, it's more expensive than FOBT, and really the studies that really give us a good sense of the interval and relative efficacy compared to sigmoidoscopy or FOBT really have never been done. So because of all these issues, fecal DNA has really been mostly relegated to the sidelines. And then the most recent addition to our armament, and one that's gotten a lot of press over the last 5 years and continues to, is CT colonography, or virtual colonography as it's known. And as I said earlier, there's now some studies suggesting that MR colonography is similarly effective as CT, but without the radiation risks. So benefits: it's a sensitive test, it's minimally invasive, it's not non-invasive because they still have to insufflate air into the colon. There can be risks associated with this as well as discomfort. And it's about a Q5-year interval. Unfortunately, it's expensive. There's radiation exposure. It requires the same exact preparation as a colonoscopy, and I think this is one area that patients are often confused. They think you just walk in and get your CAT scan and walk out with your colon cancer screening. Unfortunately, it's just not that easy. And the other thing is that if it's positive, then you have to go back and do your colonoscopy, which often cannot be done the same day. So anytime it's positive, you're sort of asking a patient to undergo a double prep, a double procedure. And the other thing, which can kind of go into either the benefits or the cost section, is the incidental findings. And the risk of incidental findings on CT colonography is not insignificant. A fair number of patients will have something else found. And sometimes that's a benefit, such as an early renal carcinoma, but a lot of times what's been seen in these studies is they find small incidental lesions which really are clinically meaningless but yet require additional workup and additional risks. So there's a lot of issues, and it really has kept, beyond the insurance issues, it's kept CT or virtual colonoscopy from being a prime screening test. On the other hand, I think for patients who fail a colonoscopy for any reason, due to anatomy, they've had abdominal surgeries and have a lot of scar tissue, they don't respond well to sedation, this can be a very good test for them.
So those patients have already had a prep. The gastroenterologist attempts a colonoscopy and then says it's time to quit at a certain point, either because of adhesions or the anatomy, and then it would be appropriate to send that patient from the GI endoscopy suite to the CT seat and have a CT colography.
Yes, in an ideal situation, that is how it goes. And that's how we are able to do it at our institution, but that took a lot of coordination between ourselves and radiology to be able to have same-day rapid CT colonoscopy after a failed colonoscopy. It also requires some deftness with the insurance to make sure that they're actually covered for that, so they're not getting a big bill a couple weeks later and then having to fight it. But yes, that's an ideal situation, and wherever possible, I think that is the sort of system that we should be setting up. So getting then to a risk and when we start and how often we do and in what population. So starting with our average risk patients. These are people with no family history of colon cancer or advanced adenoma, or a single first-degree relative with colon cancer or advanced adenoma over the age of 60. And this is actually one of the first points I really want to make, is that in the recent American College of Gastroenterology / American College of Physicians guidelines, they do add in this new second category for average risk, where if you have a single family member with an adenoma or colon cancer at an advanced age, that doesn't necessarily put you at higher risk, and you can start colorectal cancer screening at the same age as the general population at 50. This is not what the American Gastroenterology Association and U.S. Preventive Health Task Force has come down on. They've kept anyone with a first-degree relative of an adenoma or colorectal cancer starting at the age of 40 or 10 years before the earliest cancer or adenoma in the family. And probably, in all honesty, the truth is somewhere in between, and this really has to be on a case-by-case basis. The problem is, and the reason the recent ACG-ACP guidelines have taken this out, is because a lot of people were coming in with a single family member, say their mother got a polyp at age 70, or they weren't exactly sure what the polyp was. They thought it might have been an adenoma. To start that person at age of 40 for colonoscopy seemed honestly like overkill. And there really wasn't a lot of benefit to be seen in that population. So this is something that's in flux, but it is something to at least consider. Again, as I said, African Americans starting between age 40 and 45 if possible. All others start at age 50. With the three main choices: colonoscopy Q10 years if negative, flexible sigmoidoscopy every 5 years, or FIT fecal occult blood testing every year. So moderate risk breaks down into two really different categories. There's a moderate family risk and a moderate individual risk. And so moderate family risk is this. This is a first-degree relative with colon cancer or advanced adenoma at age less than 60, or again, according to U.S. Preventive Health Task Force, at any age, or greater than one first-degree relative with colon cancer or advanced adenomas at any age. And for these individuals, these are sort of the ones we're typically thinking about as a little bit higher risk. They're starting at age 40 or 10 years prior to the earliest lesion, be it adenoma or cancer. And for these, you take a lot of the other options off the table. Anyone at above average risk needs to go straight to colonoscopy. There's really no justification for most patients to do anything except a colonoscopy when they have higher than average risk. The recommendations are to start at colonoscopy every 5 years, but you can consider increasing the surveillance interval after repeated negative tests. So they have one at 40, they have one at 45, it's both negative, maybe they have one at 50. Probably can go at that point to every 10 years. Again, all of that is based on modeling data. There's no prospective study that says for sure that that's the appropriate interval, that that's the safe way to do it. But that's what most people are doing in practice, and that's in general supported by expert consensus statements. So for moderate personal risk, things are a little different. So if you have a personal history of a non-advanced adenoma, and I'll be going through all the definitions of advanced versus non-advanced adenoma in just a few slides, you continue with a colonoscopy every 5 years. If you have an advanced adenoma or more than 3 adenomas on any single exam, you should undergo a colonoscopy yearly until there's no further adenomas, and then every 3 to 5 years after that, depending on the number of colonoscopies it's taken, whether and the size of the lesions. And finally, if you have a personal history of colon cancer, you have a colonoscopy at 1 year post-cancer resection, and then again every 3 to 5 years after that. So one topic that's come up a lot recently is colorectal cancer screening in older adults. And many of you probably saw, and this is in the references, a recent JAMA article suggesting that there's an excess of colonoscopy being performed in the older population now. That really does not confer significant health benefits, but does confer significant risks. So the current recommendations are these. Routine colorectal cancer screening is not recommended for anyone over the age of 85, excuse me. In individuals between the ages of 75 and 85, or with a predicted life expectancy of less than 10 years, the risks and benefits of screening should really be discussed. However, I would note that this is screening. These are people without a past history of adenoma. So if you don't have a past history of adenoma, there's no reason to screen over the age of 85. And really between 75 and 85, you should really have the discussion of whether that in general is going to be a benefit to the patient and consistent with their own values. It's much less clear when to stop surveillance in a patient with a history of adenomas. And this is something that really, again, requires some individual discussion, but I think many of us right now are using something around a 5-year life expectancy or an age of 85, or really even if they have a history of adenomas, if they are not in very excellent health, then you can consider not repeating the colonoscopy. And again, decision to proceed on colonoscopy in anybody with any risk factors over the age of 75 should really be based on the patient preferences, life expectancy, comorbidity and risks of complications, and the ability to tolerate the preparation and procedure. Because if they can't tolerate the prep, then sending them to colonoscopy is not going to be useful. Again, if they have a lot of comorbidities, congestive heart failure, they're on aspirin, Plavix, or blood thinners, then the risk of colonoscopy goes way up, especially if you remove a polyp, and that's really the reason why you'd be doing the colonoscopy. And that's something that really should be factored into the decision to send somebody back to colonoscopy at an advanced age. So going over the polyp varieties, and there are 5 major types, and we'll go through each one because they're all fairly common, and they change how we think about a patient and when they should be coming back for their next colonoscopy. So there's hyperplastic polyps, adenomas, advanced adenomas, serrated adenomas, and sessile serrated adenomas. So the first are hyperplastic. These are very, very common. They're an increased growth of normal colonic epithelium. These have no malignant potential. And people with hyperplastic polyps alone in general can undergo a normal 10-year follow-up colonoscopy. There's no increased risk for the vast majority of patients with hyperplastic polyps. On the other hand, if you can consider a large, if you have a large adenoma, sort of greater than a centimeter, greater than a centimeter and a half, or greater than 4 adenomas proximal to the sigmoid colon, these patients probably have a slightly different phenotype. And while the lesions themselves, the hyperplastic polyps, don't turn into cancers, it does suggest that they may have a increased risk of colorectal cancer as sort of a field defect. And these people you may want to follow up a little bit more commonly, although that is an unusual set of scenarios. So adenomas are bread and butter for colonoscopy. As you all know, these can be tubular or villous. These have increased glands and cells with hyperchromatic nuclei showing metaplasia and increased mitosis. There's about a 5-year progression to malignant transformation. And again, this is why we set the interval at 5-year follow-up for colonoscopy, because we think that if an adenoma is missed, it'll take 5 years before it'll turn into a cancer, and we'll have a chance to go back and get those early. Finally, advanced adenomas. These are any adenoma that's greater than 15 millimeters, 1.5 centimeters, any adenoma at any size that has dysplasia, or more than 3 adenomas found on a single exam. These patients have a significantly increased risk of colorectal cancer compared to patients with just a non-advanced adenoma or less than 3. Again, and in these patients, they should have colonoscopy yearly until there's no further adenomas seen, and then a colonoscopy every 3 to 5 years after that. So the next two can get confusing, serrated adenomas and sessile serrated adenomas. These are actually quite different in pathology, even though they're named very similarly. So serrated adenomas are a combination of hyperplastic and adenomatous features. So they're sort of a hybrid. And although you might think that a hybrid adenoma hyperplastic would be less bad, and actually it's actually more, it has a higher risk of going on to colorectal cancer progression. They have a higher risk of having microsatellite instability mutations, which are a marker for colorectal cancer progression, and also DNA methylation. Again, elevated risk of malignant transformation, and anyone with a serrated adenoma should come back for colonoscopy in 3 years. And finally, a sessile serrated adenoma, also known as a sessile serrated polyp. And these are sort of the newest common polyp to be added. Their terminology has changed a bit in recent years. This is not a true adenoma. This is actually a hyperplastic-like polyp, but with increased serration and without many goblet cells. So they're a little bit like a malformed hyperplastic polyp. These can be treated just like an adenoma in most cases with a repeat colonoscopy in 5 years. They have sort of an intermediate malignant potential, very similar to an adenoma risk, even though they're a different pathology. And then there's just a few other types of polyps that are worth knowing about, although they're much less common. First is juvenile polyps. These are the most common polyps found in children. This is granulation tissue over cystically dilated mucin-filled ducts. And these are really can be considered incidental outside of genetic syndromes such as juvenile polyposis syndrome. And inflammatory polyps. These are not true polyps at all, but they're reactive growth in the setting of chronic inflammation. These are typically seen in ulcerative colitis, but can also be seen in things like chronic diverticulitis. And again, these do not increase your risk of malignancy and do not by themselves require any change in follow-up surveillance colonoscopy intervals. So getting on to some special populations. So we've run through most of the sporadic cancers, most of the common things. The first one is hereditary colon cancer syndromes. The two main ones to know about are hereditary non-polyposis colon cancer, HNPCC, or Lynch syndrome. And the second one, less common, is familial adenomatous polyposis. And then there's also non-genetic conditions that dramatically increase your risk of colon cancer. The major one of these is inflammatory bowel disease. And secondly, primary sclerosing cholangitis, with or without that background history of inflammatory bowel disease. And we'll go through each of these just briefly in the following slides. So HNPCC, this is a complicated syndrome of tumors. This is a defect in DNA mismatch repair genes, MSH or MLH genes, which lead to changes in DNA, increased risk of mutations throughout, and this is inherited defect, so it's something that is in all tissues. And as you would imagine, anything that causes a defect in DNA repair can cause cancers in many other parts of the body beyond the colon. And that's true. And what you see in the box with the HNPCC cancers is that endometrial cancers are actually very common. Gastric cancers, ovarian cancers, hepatobiliary cancers, urinary tract, small intestine, and CNS all are related to HNPCC. The criteria for HNPCC diagnosis are as follows. They're known as the Bethesda criteria. These are any colorectal cancer or endometrial cancer under the age of 50, any 2 or more HNPCC-related cancers at any age, a colorectal cancer with microsatellite instability under the age of 60, and that's a test that pathologists will do on every colorectal cancer routinely these days. Colorectal cancer with 1 or more relatives with an HNPCC-related cancer at age 50, or colorectal cancer with greater than 2 relatives with HNPCC-related cancers at any age. So these are tough to remember, and actually what I recommend to the average clinician is not that you keep the Bethesda criteria in the back of your mind because they're difficult and tricky, but just to remember that if you're seeing young onset colon cancers, if you see a family history with multiple different cancers scattered across multiple different members, these are all patients who you should consider may have HNPCC or Lynch syndrome. They should all be referred to a genetic cancer clinic to talk about what the appropriate screening is. And for colorectal cancer, they should have a colonoscopy every 2 years starting at age 25 and then every 1 year starting at age 40. They have a very increased risk. And again, because that 10-year progression from adenoma to cancer really doesn't apply to this population, so the 5 and 10-year intervals don't apply. And especially for women in this population, they need to be considered for prophylactic hysterectomy, oophorectomy because of the high risk of endometrial ovarian cancer. So this is something that you really want to keep in mind when taking a family history. The second condition, which is less common, about 1% of colon cancers compared to the 5% of colon cancers for HNPCC, is FAP, familial adenomatous polyposis. This is an autosomal dominant disease, so you should get a good family history of this. In the APC gene regulating beta-catenin, this is a very significant tumor suppressor gene. The diagnostic criteria for this are much easier, greater than 100 colonic adenomas and 20 to 100 colonic adenomas for attenuated FAP. And similar to HNPCC, it's associated with a variety of other cancers, so once you've made this diagnosis, they need to be screened for a variety of other cancers and also referred to a genetic cancer clinic. This is a little bit different. This doesn't require colonoscopy at all, actually, even though it's a high risk. This just requires sigmoidoscopy every 1 year, starting at the age of 12 to the age of 40. If they don't develop by the age of 40, then they're not at risk. And they require a colectomy if possible. And this is the reason why you don't need to do anything more than a sigmoidoscopy. This is a patient with FAP who got diagnosed early and underwent colectomy, which for the colorectal cancer risk at least is curative. But you see, you're not going to miss the polyps. Even with a sigmoidoscopy in a typical case, you'll see 50 plus adenomas in a sigmoidoscopy, and you can make the diagnosis very easily. So the next is inflammatory bowel disease. There's about 1 million cases of inflammatory bowel disease in the United States, and I know you'll be hearing about some of this in your next presentation. But just in brief, it's an equal prevalence of ulcerative colitis and Crohn's, but one of the major long-term risks for patients with IBD is risk of colon cancer. And the main factors that increase your colorectal cancer risk are long duration of colitis, extensive colonic involvement, a family history of colorectal cancer, even outside of people with inflammatory bowel disease, and a history of primary sclerosing and cholangitis. So for patients, your patients with inflammatory bowel disease, your recommendations are as follows. If they have colitis involving more than a third of the colon, they should start annual colonoscopies at 8 years. If they have less than a third of the colon, they can start colonoscopy a little later, around 12 years. If they are diagnosed with PSC, and anyone with a diagnosis of PSC is at an increased risk of colorectal cancer for reasons that are not entirely clear, they should start colonoscopy yearly. If they have proctitis alone, however, they don't require surveillance. They do not appear to have a significantly increased risk of colon cancer. What you're looking for with IBD is not polyps necessarily, but really dysplasia. And for this, you take 4 biopsies every 10 centimeters of normal appearing mucosa, and separately for anything that appears abnormal. And with a proctocolectomy recommended for anyone with high-grade dysplasia, and at least considered for patients with low-grade dysplasia, depending on their age and comorbidities. So moving on to some of the quality improvement and quality assurance aspects in colorectal cancer and diagnosis and prevention, because really this is a screening test for the entire population and something that has a significant cost to society and something we want to make sure we're doing as accurately as possible. So I just wanted to go over some of this really quickly, because this is an area you'll be hearing a lot more about in coming years. So the major topics are ensuring appropriate screening and surveillance, avoiding inappropriate screening and surveillance, minimizing complications, and maximizing diagnostic yield. So just quickly to show you that there is an issue, although we've done much better over recent years with screening in general. The screening rates vary dramatically by location. And in some areas, like the Northeast, we actually do very well with rates above 70% in most places for colorectal cancer screening uptake. In some parts of the country, in some demographics, they are much lower. And each area needs its own tactics for improving screening recommendations, but really this is an area where we can see a lot more improvement, again, but hopefully by offering different tests. Not only is it different by geographic area, it's also different by ethnicity. You'll see at the top line in this colorectal screening uptake across the United States by white non-Hispanics. The dark black line is the overall population. We've seen actually great strides in African American screening over the last 20, 30 years, with them catching up much of the way from before. The area with the biggest disparities right now for colorectal cancer screening is actually Hispanics. And really we are in need of really good strategies, targeted outreach for this population, because they are at risk of colon cancer at the same rates as whites, but this is the main area where we have some room for significant improvement at this juncture. So going to minimizing complications. So this is important to know about so you can adequately inform your patients if nothing else. We expect overall about 2 in 1,000 patients to have some adverse event related to colonoscopy. The good news though is that most of these are very minor. The most common complication is post-procedure abdominal pain requiring a medical evaluation, seen by the gastroenterologist, seen in the emergency room. So about half of all events are just abdominal pain, which turns out to be nothing, just gas pockets in the colon. It's something to be aware of. Thankfully, the more serious complications are quite rare. There's about a 1 in 10,000 risk of perforation, a 5 in 10,000 risk of bleeding requiring hospitalization, and the mortality rate from complications of colonoscopy is well under 1 in 100,000. So again, while complications and discomfort are common, this is actually a very safe procedure where the overall risks in terms of mortality or prolonged morbidity are quite low. The next thing we should talk about is colonoscopy FSE in the last few slides. So the first thing to know is that colonoscopy, unfortunately, is not perfect. It is our gold standard test, but it is We do not catch every polyp. The expected polyp miss rate is about 20% actually, but it's highly dependent on polyp size. About 25% of polyps under 5 millimeters can be expected to be missed. About 10 to 15% of polyps 5 to 10 millimeters, but very few polyps less than a centimeter, greater than a centimeter, will be missed. Less than 2% of polyps of greater than a centimeter in size will be missed on colonoscopy. The major things that affect polyp miss rates are polyp morphology. Flat lesions are more difficult to see than pedunculated lesions, and prep quality. Poor prep quality is a major reason that polyps can be missed, and a major reason for increasing surveillance interval. So bringing the patient back sooner is a poor prep where you can't be sure you've seen all the lesions. So we're measuring colonoscopy efficacy in new ways these days. So the ideal measure of colonoscopy quality would be interval colorectal cancer. So after your colonoscopy, before you come back for your next colonoscopy, did you develop a colon cancer? This shouldn't happen if we're doing a good job theoretically. However, this is a rare event. There's an extended lag time, years before we could measure this, and loss of follow-up is common. Patients move. It's hard to know if the patient you scoped 5 years ago got a colon cancer a couple years later. So because the benefit of colonoscopy is based on the removal of premalignant adenomas, the adenoma detection rate, or ADR, has become our logical surrogate as the current gold standard for colonoscopy quality. And this has overtaken withdrawal time alone as a useful quality metric. So just because this is something you will be seeing more and is something that patients are starting to ask for and is starting to be reported for individual institutions and gastroenterologists, adenoma detection rate is dependent on age, gender, and ethnicity. But in average, we expect an adenoma detection rate of greater than 25% for men. So that's the number of the percent of patients who undergo colonoscopy with an adenoma found, and of 15% for women. However, this is greatly, the rate you get is greatly dependent on sample size. And so I would be very cautious about asking, if you're asking your gastroenterologist or you are a gastroenterologist looking to report this, that you have an adequate number of screening colonoscopies to report this. If you're going in and saying, I had 10 colonoscopies yesterday and 4 of them had adenomas, so I have an adenoma detection rate of 40%, you actually have a confidence interval of somewhere between 10% and 80%. So really you need a good sample size. I recommend at minimum 100 screening colonoscopies to generate a robust adenoma detection rate. I'd also be very skeptical of global adenoma detection rates greater than 40%. This is probably a limit, either a very specific high-risk population or a small sample size. It's also notable that low adenoma detection rates may be a sign of overscreening, so bringing people back too soon rather than poor technique. So there's many ways you can interpret these results. So just to end up, and then whatever time was left, I'm happy to answer any questions. But I think in the future, it's pretty certain that colonoscopy will not be the dominant screening modality for average risk patients. I think for moderate and high risk patients, colonoscopy will always be the test of choice. But in the future, we'll see non-invasive and prepless screening tests. Radiologic, fecal, it's not entirely clear, with high sensitivity and modest specificity, will be the first line tests for the general population, with colonoscopy as the follow-up for any patients with a positive result. So again, I see actually the role of sigmoidoscopy probably lessening in future years, where low-risk patients can be ruled out with a non-invasive test, and high-risk patients with a positive non-invasive test will go straight to colonoscopy. I also see that pay performance will mandate really high levels of screening for the general population, necessitating creative approaches to outreach and screening. But the good news of all this, and that of all this work that we're doing, is as a result, the colorectal cancer incidence and mortality will see it continue to decline in the coming years. And I'll just leave some of my references up on that last screen.
Terrific. Thank you very much, Dr. Leffler, for a very comprehensive and clear talk covering a very important topic. We have time for a few questions. One of them is from Dr. Mohammed Ida. What is the management of low-grade dysplasia in inflammatory bowel disease?
Yeah, so that is a great question. One of the difficult things about low-grade dysplasia is subject to inter-observer variability by the pathologist. So the first thing I would recommend with anyone with low-grade dysplasia is get a second opinion from a really top-notch GI pathologist if you haven't already, and make sure that is actually what it is. For low-grade dysplasia, it really depends. If this is a patient who's young and healthy, post-childbearing in women, perhaps hasn't responded so well to therapy for the colitis, you'd actually think about colectomy in that patient. If there's an older patient resistant to colectomy, then this is something you'd increase. You'd probably do a colonoscopy again in 6 months, again a year after that, just to see, make sure to see if the dysplasia is unifocal or multifocal, if there's any foci of high-grade dysplasia to help guide your thinking on this issue. But it really is case by case, and many patients can just be monitored with low-grade dysplasia for progression to high-grade dysplasia.
Terrific. Dr. Charles Crookall is asking, how can withdrawal time not be considered a metric for screening? I agree ADR is more accurate. However, ADR is directly dependent upon withdrawal time of 6 minutes or greater during well-prepped colonoscopy in nearly all.
Yeah, this is something that has been a very interesting issue to follow over the last couple years, the last 5 or so years. And I think in the beginning, the studies were really, at least observational studies, really strongly suggested that withdrawal time was one of the major factors influencing adenoma detection rate. But what some further studies, including a large one done by my close colleague Mandeep Sahani, it showed that most of that correlation was actually driven by a very few number of very quick withdrawers who really were not doing a good job. So the 2 or 3 minute withdrawers. And whether you did 5 minutes or 8 minutes or 10 minutes made very much less difference. And actually in some prospective studies where they actually took divisions and made everyone have colonoscopy withdrawal times of over 7 minutes, you really didn't see any change in adenoma detection rates for the majority of gastroenterologists. Again, there was that small number who was not being careful. So I think, I think those types of data are the main reason it's sort of fallen by the wayside. I do think it's important, and I think if you have a doctor who's having recurrent adenoma detection rates that are low, it's one of the first things you want to look at. But by itself, I don't think it can be considered an adequate quality measure.
Okay, a 5-second response. What is the future perspective of capsule screening colonoscopy?
I think capsule screening colonoscopy will not be prime time because it still will require a prep, and I think the curvature and insufflation of the colon for the capsules to see around all the folds. So I have trouble believing that capsule colonoscopy is going to be a good answer for us in the future.
Terrific. Thank you so much again.
Thank you.
I'd like to thank Shire, Vero Pharma Incorporated, UCB Inc., and Ferring Pharmaceuticals for their support of this important educational activity. Please remember to complete the quiz at the end of the session to secure your CME credits, and stay tuned for the next session, Inflammatory Bowel Disease, What Every Clinician Needs to Know, with Dr. Adam Shafitz. My name is Dr. Chopra. Thank you for joining us. Terrific.